including resources for fathers and male partners. By tailoring services to community needs, Healthy Start aims to reduce disparities in maternal and infant health. We have an engaging lineup in discussion followed by a question and answer session, allowing for meaningful dialogue and the sharing of important information. Our goal is to empower you with knowledge needed to make informed decisions about your healthcare options. And before we get started, I just would like to go over a few housekeeping, which is our exits are on each side of the wall, and then our bathrooms are to my right, your left. And the men's bathroom is on the other side of the elevators. We also have some snacks in the back, so if you all would like some snacks, you can get some snacks and some water. And also, do not forget to sign in. And we also have for the question and answer session of it, we would like for you all to put your questions in the chat for our folks online. And then we also have some note cards to write your questions down if you would like for one of our staff members to read it out, but you also have the option to vocalize your question as well. And I am going to pass it over to my colleague, Samantha.
So today we have 4 panelists. Can you please introduce yourself?
Yes, my name is Dr. Rafael Rivera Jr. I'm a dentist here in North Carolina, a member dentist of North Carolina Dental Society and affiliate member of North Carolina Academy of Pediatric Dentistry. I do not represent those organizations in particular. I am a Medicaid provider. I've been doing this over 27 years now. My organization is called Smile Starters. We've got 9 locations from Asheville to Wilmington, and 90% of what we do is Medicaid based. So hopefully I can lend a little bit of insight to what it is that we do and what it is the state's able to offer.
My name is Leroy Hodges. I am a community retail pharmacist, Quick Med Pharmacy, Westwood Shopping Center. I've been a pharmacist now for 20 years, graduated from UNC Chapel Hill, grew up in this area, proud graduate of Pine Forest. And at my pharmacy, we do have a good amount of Medicaid that we service.
My name is Jasmine Conyers. I am the community relations rep for WellCare in Region 5. This region is particularly important to me because I grew up right in Columbus County, so a neighboring county. So I am particularly interested and invested into the communities in Region 5. What I do is I go out, I do outreach, I let the members and potential members know about the value-added benefits that you can get through Medicaid, through our healthcare plan in particular. We are one of 5 of the MCOs that cover the Medicaid recipients. In the state of North Carolina, we partner with local municipalities, school systems, we partner with businesses, providers, and other nonprofits in the community just to bring awareness and to share a little information about health disparities and to try to help tackle some of the social determinants of health for the community. So thank you, and I look forward to being here today.
Hi everyone, I am Angela Tatum-Malloy. I am a community doula. I'm also a lactation consultant with Mama's Village Fayetteville, which is located right in the heart of our downtown. I am also a doula mentor and trainer of about 25 doulas across the Sand Hills and eastern part of the state. We are currently navigating through the various value-added benefits that is being offered with several of our plans and talking to those companies to make sure that not only is it providing a service for our community members, but to also make sure that it is a service that is valuing the support that our doulas are providing our community members. And I'm looking forward to whatever I'm able to share as well. I'm born and raised here. I have 4 generations here. I'm a proud graduate of Douglas Byrd. Also graduated from Fayetteville State, and I did my clinical lactation training at UNC Chapel Hill.
Okay, thank you so much. We did want to introduce our Healthy Start team. So our Cumberland County Healthy Start team is consisted of Sabrina Guy, Lakai Jenkins, Shakia Atkinson, and then Dion Prince. So our goal today to explore the recent changes to Medicaid plans and the expanded services within provider networks. This panel will provide valuable insights into how the updates impact access to care, offer guidance on managing new benefits, and answer questions for patients seeking clarity. The panel will consist of a series of engaging discussions followed by a Q&A session with the audience. We anticipate that this event will foster meaningful dialogue and generate new information needed to assist clients in making informed decisions about their health care options. So today we'll just be going over some different things about Medicaid that it provides health care to eligible low-income adults, children, pregnant women, seniors, and people with disabilities. The agenda for today, from here on out, we'll just be going over some Q&A questions. And again, if you have any questions, please put them in the chat. Those of us joining in person, please feel free to ask questions when Q&A time begins. First, I want to go over the landscape of Cumberland County, just so people are aware of what our demographics are looking like. So we are fairly diverse. Most of our population do identify as white non-Hispanic, with followed closely by Black or African American non-Hispanic. And then after that, it is very diverse mixture of various races, both identified as Hispanic and non-Hispanic. A lot of questions we're going to ask today deal with dental and orthodontics for some of our new Medicaid enrollees. And then we'll also talk about Medicaid expansion and what that means for the residents of Cumberland County and North Carolina, and what that means as far as new oral health benefits. So Medicaid has adopted some procedure codes and descriptions in the code on dental procedures and nomenclature. So we just want to just have everyone aware that there are new benefits for dental services, so that our residents can treat diseases, maintain their oral health, and then treat injuries or impairments that may affect their general health. There's also been some prescription drug and pharmacy updates. And so we will be going over some pharmacy benefits and talking about the pharmacy program, which offers comprehensive prescription drug benefits, ensuring low-income North Carolinians have access to the medicine that they need. So first question that I would like to ask our panel, what overall services does North Carolina Medicaid? That you know.
I can start with what I know. Currently, Medicaid covers lactation. So if you have lactation consultants, and it's only IBCLCs, International Board Certified Lactation Consultants. Currently, they do not cover services that are provided from certified lactation counselors or your CLCs. So it does cover Medicaid if you find a provider that is accepting it. Currently, there is not a Medicaid policy for doula services, but our managed care plans, currently 3 of them, and possibly a 4th one, 3 of them have them as, or will have them as, a value-added benefit. One of them has it as covered services that goes through credentialing through Medicaid. And we are actively conversing with all 4 of those to be able to help that being utilized in our state better.
On the dental side, I can say that Medicaid covers diagnostic services, preventive services, restorative services, and emergency services. So what that look like, basically, if you are covered under Medicaid, you have the ability to visit a dentist for a dental emergency. The doctor can diagnose the problem, treat the problem, put you on a recall plan to help prevent future problems. And so in addition to that, we could look at, on the restorative side, actually fix the problem, and then for any additional services you may need down the road as well, you know, when it comes to a toothache or what you may need, hopefully not a toothache, but those services will be covered as well.
So from the pharmacy side, Medicaid covers at least in my atmosphere, it covers many oral medications such that treat high blood pressure, diabetes, high cholesterol. What Medicaid has done, just like other insurance companies have done, is they've gone through and created a formulary so that there's a preferred list of medicines for different categories, and they will help patients with those medicines and either provide them at no cost or a low cost to the patient.
One additional thing that is important to the work that we do in supporting our families, especially our Black birthing people in the community, is making sure that they know that Medicaid will cover a blood pressure cuff, especially if you're having to monitor your blood pressure. Sometimes it can be challenging getting that prescription from your provider. So that's where we'll do is we come to help advocate for that. We've had to assist several of our clients in getting that prescription so that they're able to get that. But we like to let our clients know that they can get a prescription so that they can have that blood pressure cuff for monitoring.
And another additional add on to what she said, yes, those doula services will come in handy with the Medicaid recipients. WellCare is one of those healthcare plans that do offer doula services as a value added benefit. For one of my virtual baby showers that I had about 2 weeks ago, I had a guest doula there who spoke to the ladies about doula services, and it was quite a large number of them were very interested in the doula services because they had no idea. So, you know, anyone online or anyone here in this room, please spread the word. Make sure that they're calling their particular plans about those doula services, because services that Miss Angela can offer or other doulas in the area can really help these women, especially if they have Medicaid, because a lot of them think because they have Medicaid they can't have access to these services, but they are available, you know, out in the community.
And I could clarify just a couple things real quickly. So when I said restorative services, I'm thinking big picture. So that it may even, additional services that are going to be covered are going to be something like oral surgery, endodontic services, and orthodontic services to some degree. So, you know, if you need to see an oral surgeon to have a tooth removed, that's covered. If you need a root canal, that's covered. And again, orthodontics with limited coverage there, as well as prosthetic services if you're missing teeth. So just to clarify. Mm-hmm.
I do have an additional, I forgot to add this too. Medicaid can also cover equipment. I know Miss Angela had mentioned like the blood pressure cuff, but it's other medical equipment that, you know, patients might need if they have other ailments that Medicaid also can cover through their benefits. So that's also great to know as well.
And sorry, I add something that I thought of, like you said, in my pharmacy, diabetic testing supplies are a big thing also. And those are always covered under Medicaid too, because that can be very expensive if you don't have insurance. But diabetic testing supplies are a big thing too, you know, are covered.
And to help the community members, if they get a little like overwhelmed, like how do you find out for each individual equipment that we're mentioning? If you can find a durable medical equipment supplier, a DME, you can Google that, durable medical equipment, and once you call them, let them know what coverage you have and the equipment that you're looking for, and they can also let you know if the insurance that you have covers the equipment that you're seeking.
How is Medicaid expansion changing North Carolina Medicaid affordability?
So I can start. So prior to this position, I was at Hope County doing adult Medicaid, and I was there 12/1/2023 when expansion started, and it was explosive. A lot of adults in this region, in the state of North Carolina, period, were not able to get coverage at all. They would either have to go through the healthcare marketplace, or they would just not be able to get the care that they need. So with this expansion, it allowed adults from 19 to 64 to be able to get coverage that they otherwise would not be able to receive in the state of North Carolina, which was great. When I say we saw an increase of applications. It was a major increase, and it helped because a lot of my clients that I saw, they were telling me they haven't been to a doctor in years. A lot of them were really happy because a lot of the dental work that they needed, it affected their body holistically, like their insides was because dental work. So they were really excited that they were able to get this coverage. So with the Medicaid expansion, I think by North Carolina opening this up, this just added a new level of health for North Carolina. And then it allowed for healthcare plans like WellCare and Healthy Blue and the rest that are the MCOs to also allow the members and petition members to have access to certain benefits that we give them that otherwise they wouldn't be able to get if they didn't have this plan. So I think it was remarkable.
I'll share that from the dental side, it seems that we've got about 600,000 adults that became eligible for dental services. That being said, there's a bit of a qualifier here. We have folks that are eligible and they have coverage, but they still don't have access to care. And that's an important distinction to understand here in the state of North Carolina. The majority of dental services in our state are provided by private practitioners. And frankly speaking, we have a huge problem with our reimbursement rates right now. They have not been increased in over 16 years. So we've got providers dropping out of network, which makes it that much more difficult for these eligible recipients to actually access dental care.
I wanted to add, so you beat me to it, because I'm glad you were the one with the doom and gloom, because I'm usually the one that's always here. So, you know, when I was advocating very heavily for Medicaid expansion, but alongside advocating for Medicaid expansion, I was trying to sound the alarm that we were not going to have enough providers for the addition of the community members that we would be serving. And that's what's happening now. We just had a panel a few days last Sunday where we brought down two doctors from UNC Chapel Hill. They're on a project that I'm working with, and they can tell you firsthand, you know, providers, there are less providers in the community. There is an OB/GYN crisis here in Cumberland County. We do not have enough to cover the number of pregnant people that we're having in this community. That means that they may have access and having the insurance, but what's happening is they're not getting in until 12 weeks, 16 weeks, sometimes 20 weeks, 24 weeks. Then if they're looking for a high-risk provider, they're having to leave the county. And so, and I'll speak directly for myself with lactation. I currently do not accept Medicaid with lactation. Because I'm a nonprofit, I can still see my clients and provide that service for them. It's because of what was just said, you know, having to already fight to get paid an amount than your private payers are paying, because I get paid much more from private insurance companies for lactation versus what I would get from Medicaid. Also, with having our dual services, what I want to let everyone know that while we do have the value added benefit from WellCare, Healthy Blue, United Healthcare, and hopefully soon Aetna, we have some challenges in having doulas that are credentialed and accepting those insurances because, again, it's challenging. Myself and my partner in this business, she has an organization in Durham, Maya Jackson with Mame. We are currently working with these plans to make them more accessible. But right now, you do not have a large inventory of doulas that are accepting these plans. One plan that was being utilized, which was United Healthcare, we just got the big news yesterday that it's being acquired by another company. They were already experiencing some challenges in getting those doulas paid, and now it's been acquired by another company. So now I have to go and vet this new company and see what the procedures are going to be. So it's not, so Medicaid expansion, I don't want to, it was a wonderful thing, and we need to have coverage. Because what that did do is it took away people worrying about finding the insurance. Because here's the thing, before Medicaid expansion, they were still having trouble finding the insurance and getting a provider. So now we've taken one piece away. So that's a good thing, but we still have the other pieces. So we need to look at the other things that are affecting having access to our providers. One is going to be reimbursement. Two is going to be things and situations that are affecting our providers, especially our OBGYNs, that are causing them to stop practice and or leave the state. We have another provider that is going to be retiring. It's going to make a huge impact. So it's going to get even harder for those pregnant people to have access.
Oh, so from the pharmacy side, the expansion of Medicaid has been, at least from what I've seen from my customer base, in that it's been very beneficial in that patients now are getting help that didn't have it before. Whereas before, we had a lot of patients that were deciding whether or not they needed to buy groceries or get their medicine that month. And that's very sad to see. But that has helped a lot. And like the panelists have already mentioned, the one problem that I do see, though, is that there are less practitioners taking Medicaid. So once they do have the prescription, they come to the pharmacy, we can process everything for them. But now the issue becomes getting the prescription, because providers have dropped out. I'm assuming because of reimbursement rates is usually why. And the ones that are currently accepting Medicaid have such long waiting lists. I've heard of stories where people are waiting 6 months just to get in with a provider as a new patient. So that can be very difficult. A challenge that we see too on our end is that sometimes because we do real-time billing in the pharmacy, we electronically send the claim to the insurance company, and then we know right away whether or not the medicine is covered, how much to charge a patient. We find out right away whether or not the provider has been credentialed by Medicaid. And sometimes I feel like we have the unfortunate circumstance to let the patient know, by the way, we can't get Medicaid to pay for this because your provider who wrote this prescription for you is not credentialed by Medicaid. So they have to pay out of pocket for their medicine. But what I always warn them is that sooner or later they're going to realize that they're not in network, and then you're going to get a bill from the provider because they've been seen, but they're not going to be able to use their insurance. And that's something unfortunate that happens sometimes.
We have been asked if you all could speak up a little. The air conditioner is kind of loud.
Sure.
Yes.
The next question we have, and I guess this is mostly for Ms. Ted Malloy. If you can explain, what are maternal support services? Do you know what those are for Medicaid?
I do not. So what it should be, maternal support services should be anything that is going to aid in the prenatal period. And it's going to be postpartum, because if it's not with doulas, because we don't really refer to them as maternal support services, and it would help whoever put the comment in the chat, if they can say from what resource or location they got that phrase, that will help me explain it a little better. But let's say if it came from, they looked on their insurance website and they saw that maternal support services are covered. That could be just how that particular provider is describing a host of things, and that could include doula services, birth support and postpartum support. But I would need to know the source of where it's coming from. If it's just in general, it could mean different things, but basically it's support services. Prenatal, that could be anywhere from a home visiting provider, someone that can come and provide support to you prenatally, and then also in the postpartum. It usually, if not in relations to including doulas, it usually will not include birth support, because even with our perinatal health workers or community health workers, or the different names, they provide prenatal support up until labor, and then as soon as the baby's born, they can provide support. But it's very rare that it's going to be actual labor support unless they are a doula.
Have you heard of maternal support services? Have you heard of maternal support services?
No, I have not heard of the phrase, but when Miss Angela was talking, I was thinking of services, are they talking about, could they be talking about maybe, maternal care support when it comes to like a care manager, someone to help them through that process, to maybe connect them to resources, help them get a car seat, help them maybe have access to like Pampers or resources that they might need when it comes to clothes, household things, utility things when it comes to like maternal access and extra stressors. I think, yes, I would need more context.
Like where the phrase came from.
Yes.
Okay.
Yes, thank you. Thank you.
Our next question, this is also from Ms. Tina Moy. Through Medicaid, who is eligible for dual support? They have Medicaid, who is eligible for dual?
You mean as far as clients?
Yeah.
If you have, yes, everyone. If you have if you have the managed care plan that says that they have it as a value added benefit, then you are eligible. If you have Medicaid, what is it called? Just basic Medicaid, then you will not be covered because right now we do not have a doula policy for Medicaid. So if you have one of the managed care plans, you're able to, now the question is finding a doula that is either credentialed or utilizing that value added benefit. Okay. Now, and I think that question may be coming from possibly with the high risk component that is with one of our vet with WellCare. We're trying to define that a little more to see, is it being clinically diagnosed as high risk or is it based on social determinants that is, like on a point system that has you at high risk. So those are things we're currently trying to clarify as well. So that would be the only caveat as far as, do you have to meet a certain criteria? For WellCare, it is the high risk feature for that.
And then you did touch on this a little earlier, but could you reiterate what doula services are typically covered under the managed care plans?
Which doula services?
Yes.
Which doula managed care plans?
Yes, so what services can a Medicaid patient expect to be able to receive?
Okay, so once you've gone through and you have a value added benefit that covers it, you have found a doula that will accept it. The next step is understanding, what you can expect. So typically, it is 2 to 3 prenatal visits. We usually, so how we define it, first we're going to find out what your birth preference. We're getting away from using birth plan because sometimes when you call it a plan, you're expecting no deviation from that plan. So we're same actual document, but we are referring to it as what are your preferences. So that's the first visit, kind of getting a setting for what you're thinking, what all of the people that will be involved in this event are thinking about, what you would like to have as a goal for your birth. The next one usually is either a provider visit where the doula will go with you to your provider. We've been getting some feedback from our clients that if they're having good communication with their providers, they necessarily don't need the doula there. So we've created an alternative option for them, which is a visit with the doula to help them just understanding, their prenatal care, how to communicate with their providers when there are care plans that are being presented to them and they have questions about them, how to communicate with your provider if a care plan that is given to you may not be what you're comfortable with or you need more education. So that's that second visit. The third visit is usually a comfort measures, going over basic childbirth education, understand the physiologic aspect of birth, going through pain, what is normal, what is not normal, and also practicing some of those positions that can help with managing pain, going over breathing techniques and other things that will help during labor. Then you get your labor support that is from the time that is deemed by the doula in meeting the client at the hospital. And I say that because it's usually people think as soon as I get to the hospital, the doula is going to be right there. Well, sometimes if you go a little early and you're only 1 centimeter and there's no, you haven't had any dilation or anything, then your doula typically is probably going to support you via phone. So once it's determined that you're in active labor, the doula will then be with you at your birth and provide support. Now I'm going to get into our definition, up to 2 to 4 hours postpartum. And that's because our doulas are trained to support with basic infant feeding. So they're there to help with that first feeding. And we know it doesn't always happen within that first hour. It could be the next feeding. So they're there for that. And then typically there's 1 to 2 postpartum visits. We have that 1 postpartum visit within the first 2 weeks so that you're getting that support that was discussed with your doula for the postpartum period, making sure that you're set up well with anything that you need, whether it's a blood pressure cuff, whether it's mental health support, whether it's, getting with your lactation consultant right away. If it's other resources, you may realize that you need, to have access for some resources that you didn't think about, but after the birth, you realized that you had a need for. So that's what's usually set up in that one. And then that second visit for us, it's where we're transitioning the mother. That's usually around 6 weeks. I'm a firm believer, and I truly support. I don't like our moms coming out if they don't have to before 40 days. So our next transition is at that 6-week mark where we have you in a centering type support circle model so that you're able to then have that support up to the first year with others that have birthed around that time. So that's typically what is. It can look different for different doulas, doula agencies, but typically you should expect some kind of prenatal support, birth support, and at least something in the immediate postpartum period as far as support.
And this is for the whole panel. If a patient comes and asks, I don't know what kind of programs I qualify for, where can patients see if they qualify for any other kind of programs or benefits?
On the dental side, this is easy because dental was carved out. So you either have coverage or you don't, and you either need the services that are covered or you don't. And if you're able to find a dentist to provide those services, you're good to go. So we actually don't participate in the 4 managed care plans. So, and hopefully that will continue to be the case because any time we have seen a managed care plan instituted in other states for dental, typically they fail within 10 years. It's just not a good way to.
Within how many years?
I think it's within 10, last
Okay.
number I heard. Yeah, it doesn't work well. California had one in place for they were all in, gung ho about right at the 10-year mark, they had to pull the plug on it. It makes it very difficult for the provider to either provide the care the way they think they need to provide the care or to actually get the reimbursement they need to do it, but the second you add a third-party payer. So I think Florida is another state that had a failed plan as well. So I'm not going to say it can't work. I'm just saying that historically it doesn't work well. So dentistry has been carved out. If you have coverage, find a dentist, you're good to go.
And I'm glad you mentioned it. Just keeping in mind, and this is just for all insurances. I've heard people that say, Aetna is the worst. And I'm like, well, for lactation, it's the best. But, you have to know that's where you want to speak with the provider that you're seeking care from and trust that they can guide you in the direction in how to determine, insurance and moving through that. I know it may not help as far as if they're not in managed care, but the question was, where do you go? You can go to the website for Medicaid, and it shows the comparisons. Also, many of you that if you are already receiving Medicaid and part of one of the managed care, that envelope that you get, there's a piece of paper in there that will give you some of the basic information, because before you consider switching based off of one particular care that you want, like you want a doula, we make sure that our clients understand, let's look at all of the benefits, the value added benefits, because if there's something that you're going to have a need even after postpartum, because you're pregnant for a particular period. But if you have other medical conditions that you have for the long haul, you need to make sure you consider that. So you want to make sure that you're conversing with someone that is not just providing information just for that one service, that they're looking at you holistically and making sure that you're able to make an informed decision about all. So going to the website and seeing all of those additional benefits that are provided, and then make an assessment for your family. If you need support or help in making that decision, reach out to someone that's used to going through those different plans to help you decide how to make the best decision for yourself and your children for those benefits.
She said it all.
You know, I can't even add to it.
The one thing I would add is, and this is, for me, the thing that I really heard and the thing that we really try to impress on our patients is that you're the beneficiary. It's your insurance, and it's your responsibility to know what those benefits are. We can help, we can facilitate, but frankly, if we're hitting a roadblock with something that should be covered, you picking up that phone and calling can make all the difference in the world in getting that thing approved. So just keep that in mind. It's your coverage.
And this is for Dr. Rivera.
Yes.
Now, you did touch on it earlier, but could you expand on, does Medicaid cover orthodontics, dental implants, dentures, and things like that?
I'll try to take these one at a time. All right, let's see. I'm just writing them down, make sure I got them right here. Okay, so orthodontics. So I said yes with a caveat or something like that earlier. And so orthodontics are covered for beneficiaries age 21 and under, but it's not a guaranteed service. And this is probably the biggest thing that we struggle with trying to explain to patients. Just because you have dental coverage, you do not necessarily qualify for orthodontic coverage. Now, that could be for a number of different reasons. First and foremost, you got to be healthy. If your mouth isn't healthy, we may not provide you that referral. And even if we did, you could get to the orthodontist's office and they're going, what am I supposed to do with this? We got to put the fire out in the house before we start rebuilding the house. Mm-hmm. So that is, I think, the big thing to understand about orthodontic services. The second thing to understand is that, let's say you are healthy, what a patient may perceive as crooked teeth or malign teeth, or in parlance that I always get, teeth are jacked up, right? We may not necessarily see it the same way. There are specific criteria that must be met that the orthodontist has to look at. And so we're looking at the relationship of the jaws. We're looking at the relationship of the back teeth in particular. So you can have a little bit of crowding in the front that seems, might it appear severe to you, but to us, we go, it's just a few millimeters. Everything else lines up. You don't qualify. Now, that doesn't mean you shouldn't seek the service. The orthodontist can still request approval of the case, but it may be denied. So, and on the other end of the spectrum, when it comes to orthodontics, some cases are much too advanced. And so the orthodontist will choose not to treat the case because, frankly speaking, they'll lose money on it. And most orthodontists I know will take some of these cases on. It's not necessarily pro bono. They do end up losing money on the back end because they bill it while they're doing it, but they can't do that day in and day out with every case that presents in that particular situation. Some orthodontic cases require adjunct services from the oral surgeon or collaboration with an oral surgeon for surgical services. And depending on what that looks like, that might also be another disqualifier for approval of the case. So that's orthodontics in a nutshell. I'll kind of tackle implants and dentures together. I'll take a moment and explain that, the preferred method for replacing a single tooth that you may have lost nowadays, and with the technology we have in dentistry, is an implant. So what's an implant? Think of it as a screw that goes in the bone. Now, it's only the screw part in the bone. We then have to put something on top of that. That's the tooth that you would see in the mouth. We don't call it a tooth, but just think of it that way. Implants are not covered. So that is something you need to understand. If you're missing a tooth, that tooth would need to be replaced another way if that tooth requires replacement. Dentures or partial dentures are typically how we get there. Now, here again, depending on how many teeth you're missing or what's missing and your age, it may or may not be covered. So full dentures, actually, I'll pause there. Medicaid coverage for dentistry in North Carolina works really well for 21 and under, and I'd say, and really well for edentulous patients who are missing all of their teeth. Those are the folks that have what I would say really good coverage because they can go and pretty much everything they need is going to be covered. It's the gap in between for the folks who are missing a tooth or two where we may or may not be able to provide that replacement tooth for you because it may not get approved. We do have to request approval for those particular services. And typically it's going to be something called a partial denture. And then within the partial denture realm, there are a couple different ways we can attack it. And because of the way the reimbursement works and because of the way the coverage works, we might have to make some compromises based on what it's worth, £1,000 a cure. So, if we can prevent our patients from ever needing those services, the patients win, we win, it works out well. So patients win, we win, it works out well. So I think I covered all those.
Yeah.
Yep.
And this one is for the kid of boys. You may have touched on this already. This question says, how can someone sign up for dual service?
That they want a doula.
Mm-hmm.
Contacting one of the either agencies or individual doulas. I know it's hard to find them. I am working along with Maya to create a doula directory for our community-based doulas. Matter of fact, she's probably working on that as of now. We have started the North Carolina Community-Based Doula Association, and it's just going to make it easier and just continue on the work. She and I have been doing a lot of work around this for about 3 years now. We took the time in having conversations at the state level. They were just moving a little slower than what we felt was needed by the community. And so it's one, finding a doula. So Mama's Village, Fayetteville has doulas. Central Carolina doulas, they also have. And I'm naming those organizations where you can have access to many doulas at once so that you have a choice. I don't know all of the individual doulas because I myself am already managing about 22 doulas across the state, from anywhere from Chapel Hill all the way to Wilmington. So I'm not able to keep up with the individual doulas that are out there. We do have Divine Doula Goddess that offers doula services. We also have Rainbow Doula. She not only offers doula services, but she also specializes in those individuals that have experienced loss and are either trying to get pregnant or currently pregnant. She has special services for those particular families. So those are the ones like to get started in trying to find. Our doulas, we provide support, and also I believe Central Carolina doulas, but go to their website. But Mama's Village doulas, we have offer support in Robeson County and Moore County, Cumberland County, Orange County, so in the Raleigh-Durham, Chapel Hill area. We also have doulas in Greenville that support and provide support at ECU, and also down in Wilmington as well. So we're able to, and I mentioned that because, but a lot of our doulas, especially the ones that were trained under us, we have knowledge about providing some basic peer support level nutrition support when we have clients that have challenges with either gestational diabetes or being diabetic. Also, if they are either have gestational hypertension or preeclampsia or just some borderline higher levels with their high blood pressure. So we're able to provide that support. So the earlier we can get in, also we know that our providers, if we're going to help mothers dealing with high blood pressure, the earlier they get them, where they can get them on aspirin care, the better. So, as soon as you're finding out that you're pregnant, we would love for you to reach out to our doulas, because we have a scheduled timeline that we can take you along throughout that 9-month period, because we have prenatal support circles that you're able to go to as well. So in the visits that you're having with your doula, you're also meeting in a peer support level with other members. We also support the childbirth education classes here, and we encourage our community members to take advantage of the support that is provided here, because there are things that they can get that they may not get from their doula or other support. So that's why we make sure that our doulas are aware of what services are being provided here at the health department. So prenatal, birth, and then with the individual doula, at least for our doulas, it's up to 6 weeks with that individual doula. And then you're getting that support circle kind of support up until 12 months. So there are doulas that do support. So remember, doulas are not clinical care providers. They should not be doing anything hands-on with our community members. And we want to make sure that our community members understand that. There is a way to support a birth that is at home with that doula still operating within scope. So yes, some of our doulas that provide that support for the home births. Also though, we want to make sure that our community members are asking for their doula's insurance, because a lot of times they have insurance that don't cover them providing support at a home birth. So you should be, just like with any other provider that is interacting with you, your doula should have liability insurance, making sure that they are covered and helping them to remain in scope, especially with the coverage that they have. So the long answer is, for my doulas, I'm very particular about the ones that will provide support at home births, because you really have to know how to stay within your scope of practice. It can be a situation as easy as, the parents, they're birthing, everything's fine, and then they need to do something, and they say, here, can you hold this and hold the baby? Or can you help get the baby? You're not supposed to do that whatsoever. Families need to understand if they're, they need to have, I'm not gonna say need, they should look into getting a midwife, a home birth midwife, but we only have 10 in the entire state. Mm-hmm. And so, yes. And so that's not going to be something that will 10 within the state that do home births, let me clarify. So, you want to be mindful of what you're looking into when you say, I want a home birth. I personally will support both, but I also tell my clients that I don't hold their satisfaction in their birth experience to where they give birth, because I've experienced traumatic experiences in the home as well in the hospital. I've experienced people having wonderful experiences in the hospital just like at home. It's a matter of you educating yourself, having someone that can help you navigate your care plan, and having that bridge between the patient and the provider so that you're able to work as one on your care plan and not feel that it's something that's being just given to you. So I went into more in that, but I wanted to make sure that I answered that.
Before we take questions, we are going to go ahead and get through
Okay.
some questions. So we will have a Q&A session. Okay, our next question, you've answered this one. Someone asked about the benefits of having a doula. You have very much covered that. So this is for the whole panel. What are some of the barriers that Medicaid patients face when trying to access services?
I think we mentioned it,
A little bit.
getting a provider.
Getting a provider, for us, transportation
That's what I was gonna
is
say.
a big issue. Because a lot of people may not live near a pharmacy, so that makes it difficult, transportation.
I would say transportation, translation services,
Mhm.
interpretation services as
Yes.
well. Could be added to that list.
And also, we need to, be aware that a lot of times our, we call them clients, you all call them patients. There is some stigma to care and access when you are utilizing Medicaid and managed care versus if you have private insurance. Mm-hmm. And so I would be remiss if I didn't bring that to our patients' attention, that sometimes you find yourself having to advocate for yourself a little more with your provider or in that clinic setting because, and for various reasons, I don't want to get into specifics, outside of, for various reasons, providers have lumped sometimes all recipients of Medicaid into one group, and sometimes their care in how they approach you. And I'll give one simple example. You may have a missed visit. If it's a missed visit for someone that has private insurance, they may get a quicker call back than a missed visit from a person that has an insurance that you're already getting paid little to nothing or not getting paid at all. Okay, so that can be a barrier that some of our recipients may face.
I'm glad you mentioned that because there are actually a good number of dentists in the state that accept no insurance whatsoever. So it's not just that they don't accept Medicaid, they don't accept any insurance. Dealing with insurance on the dental side can be a real challenge for a practice. And then of course we've got some folks that, they're, for lack of better putting, they're catering to a specific patient, in their practice. And that's a reality we're going to deal with across the spectrum and in various aspects of society. But it's not necessarily everybody, but there are a good number of dentists that don't accept Medicaid whatsoever. We could double, triple the reimbursement rates, and they're still not going to. And I think it's important for patients to understand that. That being said, there are still dentists in the Medicaid dental network that are willing to help you. You just may have to wait a little bit. So the wait times to get in, many dentists that do take Medicaid do not take it on the level, say, that my practice does. We're at 90%. That's almost unheard of in the state. There are probably fewer than 5 in the state that do what we do. Yeah. And it's because it is very difficult to actually make money doing this. So most dentists will do this, and they will take a small percentage of patients each month. And so that's a problem. So,
Yeah.
What strategies could be implemented to overcome this challenge?
Reimbursement, we said that earlier.
Yeah,
So,
reimbursement.
reimbursement on the dental side, it really is. We'll get a lot of providers to enter the network if we just increase the reimbursement.
And so that's why a lot of the work that myself and Maya and other doulas is advocacy. We are actually going up to Raleigh and speaking with our representatives. I just went to a candidate forum a couple of days ago and speaking to everyone. I didn't just go on one side or the other side. Speaking to everyone. I didn't care whether you're running or not because someone's going to end up in that office. And we need you to know the things that need to be addressed. So one is getting a better payout for Medicaid, but the other is, and I'm going to go back to the OBGYN shortage that we mentioned. We need to make it easier for our mid-level providers to be able to practice without having physician supervision. Now we do have it. It was done for certified nurse midwives. But again, now you're saying you're expecting this certified nurse midwife after she hears from providers that deal with Medicaid and other insurance that they're now going to go into private practice all of a sudden and start, being able to survive. That's not going to happen right away. But what allowing other mid-level providers to not have that supervision oversight is your women health nurse practitioners, your family nurse practitioners. So that we can have more access to providers that can offer care for pregnant people. They can get started easily with a women's health nurse practitioner or even a family nurse practitioner that can go ahead and get started. So now technically they haven't had a long wait for some basic care. Even if you don't want to call it prenatal care, they can check blood pressure. They can go ahead and get some basic things checked so that by the time they get to that provider, one, now you freed up the provider from having to start and having the beginning and also throughout the middle and second and third trimester. Now you're expanding the access and you're getting those patients in sooner. So getting our mid-level providers. Also making sure if you're going to choose get knowledgeable about the resources that are in our community. We have our resources here at the health department. We have resources that are offered with Partnership for Children. there are resources at the different doula organizations. We offer some with Mama's Village, other organizations that offer things such as support in blood pressure cuffs. We don't do blood pressure management, but we do have blood pressure cuffs. If you're needing one, we can educate you on how to utilize them, understanding the numbers. So just finding those ways, but the top two is going to be expanding the type of providers that are, and it doesn't have to be just for pregnancy. Family nurse practitioners and other nurse practitioners can help in other areas, expanding our access to providers and making sure that we're getting, increasing that Medicaid payment so that we can have more providers that will accept that insurance.
I have a couple I'll run through really quick. For me, I would say advocacy. Prior to this position, I was in another one where I had a whole caseload, and I would tell my clients, you need to advocate for yourself. I can only do but so much because this is your life. So I'm here to help you. However, you have to advocate for yourself. I'm doing what I can do, but you also call. You also stay on top of, what's going on with your health and your benefits. For instance, WellCare, we have a member advisory committee. If you want to see something happen with your healthcare plan, or hey, you guys should do this, go to those member advisory meetings because they want to hear what would you like for us to do for you. They tell me all the time when you're out at these outreach events, ask the members, what would you like from us? How would you like for me to show up in the community? Also outreach, what I do, me going out to these events and letting our members know, half of them don't even know about some of these benefits. And I'm always shocked, like, I really didn't know. Okay, well, let me tell you. And then I'm like, spread the word, get the word out, let people know. Advocacy, outreach, and then for me, it's each one teach one, right? So even if, and I'm a resource girl, so even if it's not a WellCare person, member, even if it's from another health plan, you call and you see what you can get with your health plan. Check on those value-added benefits. Even if it's a private insurance, call and check and see what you can get because you never know. And then stay on top of all your insurance information. Listen, these doctor offices, they are busy. Pharmacists, they are busy. They are human too. Everyone, doulas, lactation consultants, they are busy. So sometimes they need you to give them a little nudge, and it might not even be from a place of, hey, what are you doing? It might be from, hey, did you forget? Oh my gosh, yes, I forgot. Thank you. Thank you so much. Let me get right on it. So sometimes it just takes you just giving them a little quick reminder, and that can go a long way. So that's it.
From a high level view, I would say that, looking at things, I mentioned reimbursement as kind of this blanket term, but, actually reimbursing for those interpretive services, reimbursing for transportation, making that more accessible in general. We have a dental hygienist shortage in this state. So what might that look like in my practice? Well, here's a law change that we could look at. So North Carolina only allows 2 hygienists per practicing doctor. So I might have a day schedule with 2 doctors and 4 hygienists, and I've got a whole bunch of patients scheduled on my hygiene schedule. Well, what if that doctor's sick? One of them's sick. They're staying home. I literally have to tell 2 hygienists, sorry, you can't work today, or I've got to use them in another capacity. And then I have to reschedule a whole bunch of patients because it's too many for the one. So that's a problem we have in the state. And like I said, add to that we actually have a dental hygienist shortage. So I'd like to see some policies made at the state level that actually encourage folks to go into dental hygiene. I'd like to see the hygiene programs expanded. And then the last component would be, I think we can do a better job at the dental schools in particular with encouraging more dentists to do this type of work, because it is incredibly difficult for those of us that do this to find help, young help, someone that's right out of school that wants to do this. I was recently standing around in my office the other day and talking with a couple of other providers, and we've all been doing this close to 20 years, if not more. And we're just looking at each other going, when's the next generation of folks going to step up? We can't do this forever. And that's a true statement. It's a very true statement. So we have an access to care problem in dentistry. I think it's only going to get worse. Those are, for my money, the few things I think can help.
Let me ask, do you know if there is a current policy that has been put up there, or, because I can connect you to people if you want to just get it started and write your own policy and put it up there.
So
I'd like to see.
So the North Carolina Institute of Medicine convened a task force. I was fortunate enough to participate in that, and a whole slew of recommendations were made to address the access to care problem and really just transform dentistry in the state. So I feel like the work's been done.
I'm going to tell you, you can move faster as an individual to get something done. Maya and I were able to get a policy faster than the task force. So I'm just telling you, if just giving it a suggestion or whatever, we can talk later, because that is something that needs, we need, like you said, we're all getting older. I want to be out of this work within 6 years. 60, I want to be done, hopefully. But you're right, and it's not just the new, and this is across the board, whether it's dentists, dual support, lactation, physicians, or whatever. All across the board, they're not seeing enough of the newer ones that are coming in where they are passionate enough and thinking long-term. I just had a conversation with my group of doulas, and I'm like, we can't think of this no longer as a side hustle. This is a profession that you have to look, that you're, investing in quality training, that you're looking to do this for the long haul, because we need people that are looking to build a profession. And you can't look at it as, I'll be in it while it's good, and when it's not good, I'm out. So he's right. We need to find a way. We're currently doing it in our way. We're getting ready to start going around to the high schools and doing career fairs within that, so we can let them know this is a profession to consider. But we're doing the other work on the other side to make sure we're not bringing them in and they're having to deal with, paying problem or policy issues or whatever. So that's what the association is working on, to make sure, as we are trying to attract those into doula and lactation profession, that we're addressing the issues that will make them be able to do this well and earn a living and not overwork themselves.
And this, our next question, and we talked on this a little bit, but what are some of the barriers to patient care that you all are seeing and that healthcare professionals are seeing that Medicaid patients may not be aware of? Because sometimes, as a patient, I've been put in the shoes of, I feel like my provider just doesn't care, with all of this, I feel like nothing is happening, but there are things that are happening we as patients we're not aware of. So other than reimbursement issues, than not having enough OBGYNs, not having enough dentists, what are some of the other things that are happening for you that's keeping you from doing patient care?
Staffing for us.
I was getting ready.
Staffing. Having the supporting cast to do what I do every day. So, if I've got a couple of, say, staff members out, and typically, if I'm by myself in an office, most of my locations have multiple doctors, but I have a couple locations that are single doctor practices. So I've got basically 2 patients per hour that I'm doing drilling, filling on, and then I've got 4 to 6 per hour that I need to go do an examination on. And so I'm moving. Now, I'm not going to necessarily adjust my schedule because I have a dental assistant out or 2 dental assistants out. But what I will do is it may change how many things I'm doing on that particular patient. So the patient may not realize that I potentially could have gotten more done. That's not something I'm going to advertise necessarily, but it absolutely is problematic. So when I lose a staff member, I have to pull back on what I'm doing potentially. So I think staffing is a big problem for us and will continue to be for some time.
That's the same for us. We have doula work and we need doulas. And I was speaking to 2 of the other, the one agency owner and the other organization director, and we're all looking in the same pool, trying to pull from the same areas. And so, getting enough doulas that provide the support. Here in Cumberland County, we have annually up to about 4,000 births annually. And if we are going to seek to have a healthier community, that means the resources that we're talking about we're thinking about those resources being available for all of those families. We are nowhere near close when it comes to lactation consultants, when it comes to doula support, OBGYNs, and then when they get older and they need dental care, so that, you know, like you said, prevention. So we need to have enough dentists that can support, if we're really looking to make our community healthier, what we're saying is we want access for all of those community members. And so we need to look at what are those things that we can do to be able to get to that goal. Because if not, we're still going to always be working with a small subset, and we're not changing that D- that we have to get to that next grade. So it is the staffing, the payout, and policy advocacy. Those are the three things. Because if you give all providers those things, we can. I mean, you still may have some wait time. We can manage things. Not saying we're still going to be perfect. We'll still probably forget something. I almost forgot this because I was on the phone talking with someone in Florida about policy and everything. So we're still human. We still have families. It would be nice that our providers didn't have to put 40, 60 hours into supporting the communities, but still getting paid. We should not expect our providers to meet this challenge that they all of a sudden should be paid less. That's not fair on whatever level of providers we have. We should not expect that they have to be paid less for something that they paid for and trained at medical schools and going beyond. My brother-in-law is an endodontist. A lot of the specialties that it takes to provide these services, we should not say, well, they should not be making as much. We need to find a way to have our payout system in our insurance done differently, where we are supporting managing care and keeping our patients and clients healthy versus managing problems. And we get paid more if we're managing problems. So it's just a whole wealth of things that providers are dealing with. But it's not to make an excuse. Should our patients and our clients expect to have less than because of those things? No. So we just have to communicate more. Like she said, speak to not just your insurance companies that you have. Find out what time to speak to your provider. Instead of, social media is good. I'm all for, sharing on social media. But where I've shared something on social media, I've spoken with the provider directly as well, because they can't do anything. They can't make any changes if it's in an environment where they're being attacked. And people that know me and maybe see, they're like, oh, is this Angela saying that? I will call things out, but also I'm there ready to meet with you to come up with some solutions. And that's where we need to try to get our community. We're all in this together. And so if we can start communicating, where things are not going well and what can we do, that will really help.
So can I add one thing there? It's just provider network for us as well. So care coordination and collaboration becomes a problem. So I might be working with a patient and there's certain things that I need to do or want to do, but they're going to require the help of a specialist. Yet we don't have enough specialists in network to actually refer that patient to, which makes me completely change the recommendation I'm going to give to a patient. So that's something the patient doesn't necessarily see, but it is certainly something that we have to deal with. We try to always explain to the patient that, hey, there may be other options available to you. And I may say, hey, if you can find the oral surgeon to do this, or if you can find someone to do this root canal, because to my knowledge, there are no endodontists in the state.
So my daughter had to fly, luckily her uncle is an endodontist. Yep. She flew down to Dallas to get and that is not what we're expecting No. She just had the privilege and she got to go visit family, but she had to go down, and that's what we do. If we need a root canal, we go down to, that's not accessible to, everyone doesn't have
outside of the dental school, I don't know. I know of 2 endodontists are on the provider list in North Carolina, but they don't take new patients.
Mr. Hodges, so I know that lots of times pharmacists get blamed for a lot of things that are not their fault. And so are there any specific barriers that patients are aware of that you experience?
Yeah, I would say, I guess as far as everyday operations, it's workflow issues that we have. where in a pharmacy, especially in an independent pharmacy, you are basically rewarded for filling as many prescriptions as you possibly can. And that's not just for Medicaid, that's for all insurances, right? That's how we get paid, is by filling prescriptions. And so the more prescriptions that you fill, the more ideally you get paid. With decreasing reimbursements, that pushes that even more, where you're motivated to fill more. Just like with providers, with decreasing reimbursements, you're rewarded to see more patients. So you hear sometimes of people saying, well, I had to see 40 patients today, because you're trying to make up for that lack of reimbursement or the decrease of reimbursement. And it's the same in pharmacy. We are now filling 200 prescriptions a day, making the same reimbursement that 5 years ago we would make filling 100 to 150. So because of that, you have less time to talk to patients, less time to educate patients, less time to take phone calls, less time to do other things that are, and I would never say they're not part of my job, but they're added responsibilities that you don't get necessarily reimbursed for. So that's hard to tell somebody, not just a Medicaid patient, but any patient, that, you know, after a while you run out of time. And then another thing that I would say too is that, and this comes with our operation, is that there's been a lot of, especially since COVID, a lot of supply back orders. And I know it's really frustrating when you finally get in to see a provider, you get a prescription, you go to the pharmacy, and the pharmacy says, well, it's on back order. And not only is it on back order, but we don't know when we're going to be able to get this again. And you know, the patient's been through so much already, and they don't understand. And half the time we don't understand, but it's more on a supplier thing, and or another incident, something that happens sometimes. This goes with the transportation issue. When we have to order something, usually we can get it the next day, and our delivery's late because of weather, because of a breakdown. But that patient only had transportation at 12 o'clock, but your order's not coming till 3 o'clock. We try to, as hard as we can, we try to communicate with our patients to let them know there's going to be a delay, because we don't ever want a situation where a patient is stuck like that. But sometimes it's just so difficult to just, you know, to be able to tell everyone, hey, this is what our problem is, and still keep everything going the same way that we're going. Dr. Rivera makes a good point in that I feel like we do this sometimes where, I mean, sometimes I'm just putting Band-Aids on things, and I don't want the patients to know I'm having problems in the operations thing. I'm just trying to get through that day, because we're going to make sure we're going to please as many people as we possibly can. And I don't want people to know what the struggles are necessarily, but there are a lot of struggles on the operations and on workflow that patients just don't see.
Thank you so much for answering the questions. It's been, I mean, I know that we have all learned so much. Are there any questions from the audience?
Do that. Okay, first thing to do, what are their ages that you provide service?
If you're pregnant, we provide services.
Pharmacy, you were talking about sometimes you don't have meds on the shelf. Experience, like when I had surgery, pharmacy that I normally go to, I go to meds, I was out of meds for 2 days. So then we called and have the place. So we did, so pharmacy do it not, and they don't want to do the research and say, hey, tell us where we're going to get these meds. Jack.
So what's difficult is because every pharmacy is working as hard as they can to, sometimes answering the phones are very difficult for staff. And especially when I'm calling a chain pharmacy where they're already understaffed, you can spend 15, 20 minutes just waiting for a pharmacy, someone on the other end to answer, because you go through the whole wait cycle just like a customer does. And so in my store, because we do have a limited staff, we don't just, unfortunately don't have the staff to take one person out of our workflow to try to find medicines that, especially uncommon medicines that another place might have. Now, I will say, I do try to go the extra mile. I try to find whatever I can when I can. And then sometimes what makes it difficult is then you find that and you spend an hour doing that, and then a patient says, well, actually, I need it over on this side of town instead. And so you feel like sometimes you're working as hard as you can. You find what you think is a solution, and then it doesn't work for the patient. And so sometimes, I guess we do. I do promote advocacy for yourself also. So I like to say to a patient, let's try to find it together. Let's work together. You call some, I'll call some. Let's try to find it together. Let's see what we can do together.
My other question is, we're saying about prescriptions if you don't get paid, and I know the store has, like, if you don't pick up your prescription, it's $50. And some places, and I'm not sure if all of them, they toss the prescriptions if you don't pick them up in a certain day, or they reshelf it. That's big, but that's what we pay.
Right. So if they don't get picked up, then we don't get paid. Yeah, we return them back to stock. And that is another thing in our workflow, that because that takes time too, right? To fill the prescription, and then you hold it for 10 to 14 days. The patient doesn't come to pick it up. Then you have to reverse everything else. So you have to put it back on the shelf. You have to take it off the insurance. You have to destroy all the patient specific information. And so as much time as it took us to prepare that medicine, it's the same time to undo it. And then if it's a medicine that you don't use, then we take the time to, because we don't want that on the shelf. If you're not going to use it, we send it back to the wholesaler, and then the wholesaler charges you a restocking fee. And so that can be, but all pharmacies are supposed to take it after a certain period. We have to take it out of will call, what we call will call, which is where it's waiting for the patient to pick it up. So if you don't pick it up within usually 2 weeks, it has to be restocked. Yes.
And sadly, that's like a no-show.
Yes.
You're probably not able to charge, because we do charge a fee if you don't reschedule. We do have a fee for not showing up for provider, whether it's doula services or lactation, because that's a slot. Remember, we already told, we have limited, amount of slots available. And if we held that for someone and then it's not utilized, that's where someone else could have. So we do, we try to work with families, but that's why we offer the reschedule. But the no-shows, especially no-call no-shows, you do, even if insurance is, you have as a value-added benefit, you do need to put a credit card on file, because we want to make sure, again, we want the community to realize, because at one time, doula services were done for free, volunteer. We need to let them know that this is time and energy. And, our doulas, they don't just go through a 2-day training. They're in their training and mentorship from 6 months to sometimes up to a year. And they paid for that. They didn't pay the one fee. They paid for training and to get that additional mentorship, so that they are better quality doula, and they're able to offer those additional services and wraparound support. But with that, they need the community to respect the work that they're doing in the community.
I have a question, and I'm not sure if this would be good for Mr. Hodges, or Ms. Conyers, or maybe Bugsy. So we talked a little bit about how managed care plans have some benefits that the regular Medicaid patients don't have. Is there a difference between the medications that you're able to purchase? Like, do you know that there's some medications that are on the formulary for managed care plans that aren't on the regular Medicaid?
So from my understanding, the managed care plans follow the North Carolina Medicaid preferred drug list. So Medicaid has a preferred drug list, and then the managed care offers access to that universally. So regardless of which managed care plan you have, it's the same formulary.
It is, and I know with some you might get like cash back. Like for us, we have like $10 back, or other plans might have different amounts for over the counter or different prescriptions, like you said. But it is, you know, the same. Like, thank you. I'm glad I paid.
Are there any other questions for our panelists?
And I think Ms. Humphrey should probably
Oh.
address it, because it has to do with, well, I know one of the confusions I see with folks out there diagnosed mental health with substance use
Okay.
is they've been assigned, many times folks have been chosen, but been assigned a either a standard plan, Medicaid direct,
Mm-hmm.
or tailored plan. And of course, we're finding out that if someone has a diagnosis of mental health substance use disorder, they're better placed in a tailored
Mm-hmm.
condition of severe. But in many cases, folks have already been assigned standard plan.
Mhm.
And so I understand they would be providing basic, what I'm understanding, basic mental health services under standard plans. So what can they expect as a basic mental health service? In other words, does well care cover mental health services? And so what types of services?
Now, would that be like a Trillium or Alliance kind of? What do you mean? I'm confused. I'm
Yeah,
confused.
because, so I know you asked, so, because that would, again, they would have to find a provider that accepts what they have.
Okay, so a person has well care.
Okay.
They got you.
Okay.
All right.
Yeah,
So y'all cover mental health.
we do. Absolutely, we do.
All right. So what, there's a limit to what, what services do you cover?
From my knowledge, all of the services, I haven't heard where it's a service where they have not covered. For me, I know in some of my outreach, I have been instructed to do more outreach with mental health. So there hasn't been any mental health like issues or certain, like say for instance, if we're dealing with
You cover
see, that would be like Trillium or Alliance. That would be
Well, that's my
one of
and
those.
what are the limits? But sometimes folks may be assigned well care. See what I'm saying? They may have been assigned.
It still wouldn't be a limit that I would know. Whenever they're acting, they would have accessibility to any service. I wouldn't. Where's the? You know what? Let's when we finish this, let's me and you.
Asking the question. So if someone needs an actor,
Mhm.
recommend their level of care,
Mhm.
is an actor.
Mhm.
They have well
Mhm.
as their insurance provider.
Mhm.
Who's gonna pay for it? Who would pay, who would bill?
Who would be
pay-
billed?
Yeah.
It would be Trillium or Alliance would be billed,
But they got you.
but that would be.
They don't have well care.
So, but they're acting though, and that's like a different level of, like acting would be like a different level of care aside from basic mental health. Does that make sense?
Yeah, it does. That's what I'm saying. Is that
Yeah.
if they don't have, because I understand that those services are better paid for, can be paid for.
Yes.
Tailored plan,
Yes.
right?
So they don't. Now, do they want? What are they not getting that they feel like they need?
The level of care.
Because the ACT team, for them to be on the ACT team, they should be getting the level of care that they need. For instance, why I say that is, prior to me moving here, when I worked in DC, I dealt with ACT teams. And they got all the level of care that they need. There was no.
I guess I'm asking, like, if that there are folks who have been determined
Mm-hmm,
that the level of care they need
mm-hmm,
as a mental health service is an active.
mm-hmm,
They don't have it yet,
mm-hmm.
okay? But their provider, their MCO is well care.
Okay,
So they're obviously going to have to change, probably going to have to change their insurance coverage. Right?
okay, you're right.
File for the act,
Okay,
right?
right.
So that's the circumstance I'm talking about. If they've been assigned well care or standard plan,
Mm-hmm,
and they require a higher level of care, it's just like having the coverage, one of the MCO that doesn't have the dental health services that a person.
so they need to change plans.
Exactly.
Yeah.
So,
Oh,
but you can provide some basic care for them in the meantime.
yes, absolutely, yes.
And that would be basically like what, outpatient?
Yes, yes, absolutely. They can get like the basic needs. Yes, absolutely. So counseling services, if they need medication to help kind of stabilize whatever condition, that support group services, anything under that umbrella that's not as extensive as Act Team, absolutely. Yes. That,
That's what I was asking.
yes, that level, yes, until they get to Act Team. Absolutely. See, we were singing the same song.
Yeah.
Different notes.
Would you help someone knowing that that's the level of care they need, that direct them to how they can get that, make that change?
Yeah, I would say now,
I'll just, about to.
yeah, because I'm not in that
There
part
might be a
of
care
it.
plan that you gotta.
Direct them.
Yeah, yes, I can direct them to the right place, yes. Direct them,
Sorry
yes.
for the
No, you're fine.
folks all the time.
I was like,
I wasn't.
Yeah,
concerned.
sorry.
They have folks all the time. They have been assigned
Yeah,
a coverage that won't get them that additional service they need. So
absolutely.
they have to understand how to get
And honestly, I know I have right now, I know a behavioral health care manager right now that I can, whenever we wrap up, I'll contact her and I'll get the information that we need to get the ball rolling. Okay? Listen, same tune. We're singing the same song.
We got it.
Now we're a quartet, all of us. Thank you. You're welcome.
Thank you so much.
Thank you.
For all of the questions, thank you so much for all of your expertise. So now I'm going to turn it over to my coworker, Julia, to give closing remarks.
So again, thank you all for coming again. That was very informative. We have some surveys. I'm pretty sure a lot of people did them already. So if you can fill out the surveys that are on your table, as well as these videos will be posted on YouTube, if I'm not mistaken, and on our social media websites. And again, thank you all so much.
Thank you for the opportunity.